Good evening, class. We're going to spend a few minutes tonight just going over healthcare ethics. So, first module in the class, we talked about Arrow's article that described the healthcare environment well, it was published in 63, so late 50s, early 60s. Talked about it, kind of the similar article that drove a lot of, or perceived to drive a lot of healthcare change, especially when it came to at that time, maybe HICVA, but it's CMS when we're talking about Medicare and Medicaid and TRICARE and some of the revisions to the VA system. And just most economists will, I guess, contend that it was a driving force, regarding some of those government interventions and some of the government's ability to to make changes with the way healthcare was provided. And again, we've talked about it in the past that government intervention, it's typically happens, and they do a lot of things. They talk about social equity. They talk about redistribution of wealth, but what happens when governments interfere? Well, I actually hate to say interfere. What happens are the drivers to why a government entity or a government agency, whether it's federal, whether it's state, local, gets involved in the marketplace. It's typically because of market failures. Market failures, at least in the eyes of the government, have occurred, and the government, the all-knowing government, thinks they know better than everybody else about how we should live our lives and what is the best for social welfare. So the government would step in. And then that's kind of the first module. The second module, we talked about just business ethics in general, talked about morals, talked about ethics as kind of the moral factory, talked about interesting the way, talked about not only history, but kind of interesting in the way that the authors in the text talked about business ethics, and especially when it came to kind of down toward the end of that chapter, they talk about the two types or the two approaches to business ethics. One was, you manage the heck out of it, because individuals in business, I think they talk about everybody's a liar, everybody's a crook, and we need some kind of an ethical system to manage those liars and crooks in the business world. And then the flip side of that was, let the capital market take place. Let supply and demand drive everything. As some people would contend, especially in the Wealth of Nations, it was, Adam Smith said, there's this invisible hand. This invisible hand, through supply and demand, it's going to drive markets to equilibrium. And so that's the other approach. Let the market take care of itself. Let the market police itself. So depends on whichever approach you believe in. You can make an argument for either way. And then with this third module, we're going to talk about just healthcare ethics in general. And you'll see there are some similarities. Of course, there'll be some differences, and we'll kind of get into the differences as we go along. But kind of take you back a step. So, and I'm not a coffee drinker, but let's say I am a coffee drinker, and I decide to go into, I guess, Starbucks this morning on the way to work. I go into Starbucks, and I go in and I order some kind of coffee at Starbucks, and the coffee I order, I wanted, I want some sugar and I want, some kind of cream in it. But I have an issue with, I'm lactose intolerant, and I want some non-dairy creamer. And so I give my order to the individual there at the cash register. They, take my order, take my money, and, give it to the barista that's going to whip this coffee up for me. And the barista's not paying attention to the ticket and actually puts in some, low-fat milk rather than a non-dairy creamer. And it's, I'm not terribly glucose intolerant, but it's enough to make me sick. And, they go ahead and they send it out to me, and I go get in the car and I'm drinking it on the way to work, and I'm starting to feel a little queasy. And when I get to work, it's I'm not praying to the porcelain god yet, but I can tell that something's off. And I call Starbucks and talk to the manager, or at least the person's on site there. And I tell them what I think happened. And I say, well, this barista is really good. That barista would never do that. And it goes back and forth arguing. And at the end of the day, I can tell I'm not going to make any progress. And I just hang up. And as Adam Smith says, I'm just not going to go back to that Starbucks. May never go back to a Starbucks in general. But I guess where I'm going with this, it's one thing for the barista at Starbucks or the manager on site that may not have the moral compass they need, or may not have the business ethics in place with which they expect individuals to perform by. Or you go into McDonald's and they don't put the right sauce on your Big Mac, or there's a lot of things in business that can happen, and it depends on the culture that has been developed with those management teams as to how they're going to handle it. And it's one thing to go in and get a bad cup of coffee at McDonald's, at Starbucks, or a bad burger at McDonald's, or whatever you're purchasing. And because while there may be some financial issues, and I guess there could have been some medical issues with, if I was really had a severe case of glucose intolerance, but it typically there's not a physical issue. But when we're talking about healthcare, we're talking about a whole different ballgame. You go in to see your primary care doc, or you go in to see your surgeon, or you go in to see whatever type of healthcare provider you're going in to see. And if they are incompetent, if they are unethical, if they aren't paying attention that morning when you go in to see them, things can go south in a hurry. The issue, and I think Era maybe alluded to it in his office, is as a patient or as a consumer of healthcare goods and services, it's not like you can go in and test drive it. It's not like a used car. It's not like you're going to, Carfax or some of those joints to get a used car. You can't go in and test drive that thing. You can't go in and kick the tires. You can't go in and determine how you like it based on the way you test drive. And even if you get a car that you don't like, a lot of them have, you can return it within a week, or there's lemon laws in certain states that are going to protect you to some extent. But you go in for healthcare goods and services, and you end up with a provider that, for whatever reason, either is not on their game or not up to par that day, or just are not capable of being up to par. And I've had some experiences with some healthcare providers that sometimes I've even wondered how they made it through medical school. But the downside, or something going south in healthcare, is it can be far worse. It can be either long-term issues, can result in death in the worst case scenario, but it's just healthcare is a special animal when it comes to ethics and morals. And what I'm going to talk about in this first segment is, if you read the literature or you're reading through textbooks, you can hear, or you will see, ethics in the healthcare environment. You might see it referred to as healthcare ethics. You might see it referred to as medical ethics. I've seen it referred to as clinical ethics. And it doesn't matter what nomenclature you're using, it all boils down to the same thing. What are the ethics involved, and what is the moral compass that many individuals that are functioning in the healthcare arena, what does that, or how does that impact the quality of care that each and every consumer receives when they try to access the healthcare system? And as I kind of think about, again, healthcare ethics, medical ethics, clinical ethics, there's kind of, to me, there's groups of players. I've got the health plan. We'll just start with the health plan. I've worked mostly except when I was in graduate school at Ohio State. I worked at the Ohio State Hospital some, and I'm doing some consulting work now, both on the health plan side or on the payer side and the provider side. But the majority of my experience has been in the health plan. And when we're talking about ethics, you've got sitting on top of the health plan and driving the decisions of the senior management team and the culture that they develop and implement. You've got a legal department. You've got somewhere within that company, you've got a fraud, waste, and abuse or a payment integrity uh, unit that ensures that claims are paid correctly, that members receive the services they want. Again, remember that when you're talking about a health plan, the health plan is, it's really the clearinghouse. It's the clearinghouse between the providers and the actual individuals that utilize health care. And it ensures that both parties function and operate according to the parameters within their contract. So, kind of the clearinghouse, and within that health plan, the health plan is in place again to ensure that these two units, buyers of health care or individuals that are accessing the healthcare system and the providers providing those services, again, are functioning within the contractual parameters. And one of the ways that health plans typically do it is through a payment integrity group that ensures that healthcare claims are paid appropriately. You've got also internal audit. Every health plan has an internal audit function that not only is just looking at, along with payment integrity, maybe on the provider side, but they're also looking at the internal individuals. Who are the individuals that work at the health plan? And there are stories that I've worked for some health plans before that, some of the things that go on within the health plan itself. Worked for one health plan a few years ago that individuals were actually working in the claims shop, and as claims would come in for their friends, or claims would come in for family members, they would override the claim system, process the claims in such a way that it minimized the liability, the financial liability for their friends and family members. Also worked at a health plan that we caught individuals, through internal audit that were downloading patient information and selling it out. I mean, this internal audit is an extremely valuable function within the health plan to ensure that the moral compass and the ethics or the ethical standards are followed. You've also got human resources. You've got medical management. That's the team, typically clinicians within a health plan that are ensuring that the goods and services provided to the members of that health plan are of high quality, that access standards are being adhered to, and that the goods and services required for that consuming population are there for them, and they have access to it. You've got network management that, within the health plan, not only are they negotiating the rates with these providers so that they can pass on those cost-effective rates to employer groups or to the members of those employer groups that are going to access that system, but they're also ensuring and they're vetting these providers that there's not quality issues. That's part of the credentialing process. Falls typically under network management in the health plan, and they are checking, did the individual graduate medical school? Did they have they lied on their resume? Are there any malpractice cases against them? Did they do a residency? Did they do their internship? That falls under network management. And then you've got, under health plans, you've got associations. You've got health plan associations that work for the health plans, either state, local, or federal issues for those health plans, to ensure that the health plans are being treated fairly, either by, again, federal, state, or local agencies. So that's one group. That's the first group. The second group we're going to talk about are patients. And most people give me this strange look when I talk about patience and ethics, and it's like that doesn't make sense. And well, yeah, it does, because what you have in an individual is an individual, and we're all faced with this. We have a certain level of disposable income. I have a level of disposable income. You have a level of disposable income, and how we allocate that disposable income among all of the uh, I guess, opportunities to drain that disposable income. So you've got mortgage payment or rent, you've got food, you've got, insurance, you've got an automobile, so you've got some, transportation, you've got healthcare falls in there, you've got some entertainment. There's a lot of ways that you can allocate that disposable income. And when it comes to patients or those individuals that are trying to access the healthcare system, things can get dicey in a hurry. And that's where we talk about a patient's moral compass. And we'll get into it a little later in one of the other modules, especially when we talk about billing and coding, and when we talk about the healthcare forms and the information that they ask about from a healthcare form. You're going to see that the moral compass of the patient can significantly impact the ethical situation with which they're going to be faced with when they go to see, their provider. And patients especially, well, just like when most of us go see our provider. So I go in, sit down, then typically, at least now, when I go to see my provider, they have I guess a med tech, a medical technologist or a clinical technologist comes in, takes my blood pressure, temperature, tries to, figure out why I'm there to, I've come to the office to see the doctor today. Ask me questions about, am I depressed? Do I drink? Do I smoke? Do I take drugs? Um, if I got an injury, did it happen at work? So they're trying to figure out, is it workers' comp? Was it the result of a motor vehicle accident, MVA? So they're trying to ask all of these questions and that information will be also, am I covered under more than one healthcare plan, because you're going to have to coordinate benefits. And all of that information is going to be self-reported. It is self-reported information by the patient to the healthcare provider. That self-reported information will go on the medical billing form if it's primary care doc, or if you're going at the hospital, it'll go on to the hospital billing form. And we'll talk about that again in some later modules. But that information is going to definitely impact the not only provision of services, but the payment of those services as we move forward. And so we're talking about a moral compass on from a patient's perspective. We're also have an issue of moral hazard. And moral hazard, typically we see it in property and casualty. You hear people talking about P&C insurance. So like automobile insurance, homeowners insurance, theft insurance, those type property and casualty type insurance. But and moral hazard, when it talks about property and casualty, it's more like, okay, you rent an apartment and you pay for the contents, you buy insurance on the contents, and you leave your door unlocked. Yeah, I don't care. Let somebody come in and steal it all. I'm tired of that TV. I'm tired of my iPad. I'm tired of this computer. Just let somebody come in and steal it. I've got it insured. Let the insurance company buy me a new one. And that's what we talk about moral hazard. And in the healthcare arena, moral hazard is also along the lines of, I'm a patient. I work for Bob's Steakhouse in downtown Nashville. And while I'm working at Bob's Steakhouse, they provide me insurance. They take it out of my paycheck, and I'm paying a premium. I have to pay either a biweekly or monthly premium. And because I paid that, I mean, heck, I'm going to make sure I get all of the I'm going to get all of the benefits that fall under my benefit plan. And let's say I've got a $5 copay. Heck, for $5, I can go see the doctor whenever I need to. Yeah, I'm probably going to go in and see the doctor in times when I don't really need to see him. Or the doctor gave me a prescription for medication and gave me 6 refills, and this medication happens to be a zero copay on this particular benefit plan. Doesn't matter whether I need to continue taking the medication. I'm going to take it. I'm going to get all 6 refills, and I'm going to just store it. I'm going to hoard it, and maybe I can get an opportunity to sell it. When I worked for Blue Cross and Blue Shield in Buffalo, I lived downtown in an apartment, and there was a Rite Aid right around the corner. And when I would go to get my prescriptions filled at Rite Aid, there were a lot of individuals that would come in to Rite Aid, get their scripts filled. I was in a part of, it was downtown Buffalo, so there was the specific population of individuals who got their prescriptions filled there. And I would see them go in, get the prescriptions filled, and then walk right out the door and turn around and sell the prescription or sell the drugs that they just picked up to somebody on the street. There was a huge black market going on in downtown Buffalo. And again, that goes back to moral hazard. And one of the issues with the moral compass and the moral hazard for patients is, go back to your old micro classes. What are the 3 kind of pillars that set economics apart from other social sciences? Opportunity cost, decisions at the margin, self-interest. Self-interest, one of those 3 pillars, especially microeconomic thought, one of the 3 pillars of microeconomic thought that drive a lot of the decisions that patients make. And then lastly, kind of on the patient side, so I've got the health plan we talked about. The health plan's negotiating contracts with this medical group. The medical group, at that point, the health plan's going to develop a benefit plan. They're going to turn around and sell the benefit plan to an employer group. And the employer group will then turn around and say, hey, employees, here's our benefit plan. We can go see any of these providers we want to, and we're going to be covered by health plan ABC. What happens sometimes, and I've seen it on more than one occasion, is employers and the employees have a somewhat loosely defined ethical standards and moral compass. I've seen employer groups in the past that would actually list in the state of New York, it was a tax form 45. They would list it on their 45s as individuals that were employees of the company, and they weren't employees at all. They were family members, friends that couldn't afford insurance on their own. They'd bring them on as employees, usually with the title consultant, and they'd bring them on, and they would, there was money changing hands. The employer group could buy the insurance, that benefit plan, cheaper than the individuals could buy it on the open market. So you would see that happen a lot. And again, you had, that's the employer group, and then you had the employees that were actually sharing their healthcare ID cards. And that was at a time when usually you would go into your provider's office, and you'd go into the provider's office, and especially if it was an emergency room, and they weren't asking for ID. They didn't ask for, passport. They didn't ask for driver's license. They didn't ask for a photo ID. They just took the insurance card. Patient came in. They, close enough resemblance, same sex, roughly same age. And they got the healthcare services free. They were all using the same card. So again, we're talking about healthcare ethics, medical ethics, clinical ethics, and a lot of opportunities from go sideways. Then we roll around. So that's 2 groups. We're going to round through the 3rd group. We're going to talk about the providers. Providers swear to the Hippocratic Oath when they come out of medical school. They used to, and I assume they still do. And you would expect them, once they adhere to that Hippocratic Oath, to not have an issue with ethical standards. What we're going to find probably in the next module, where we're talking about just the economic impact of healthcare ethics, the last numbers I saw, it's like 4 point, healthcare spend in 2022 was something like 4.1 trillion or something. I don't remember the exact number. But of that 4.1 trillion, 25% of it was due to waste and abuse. Waste and abuse, and most of that waste and abuse, while some could be occurring on the patient side, the majority of it's occurring on the provider side. And you've got the providers who are trying to function under a set of ethical standards, and they may be developed by medical associations, the American Medical Association, American Hospital Association, state and federal guidelines, a lot of activities going on to try to ensure and that providers are acting ethically, but it still goes sideways sometimes, and especially with providers. And again, Errol talked about asymmetric information, and so you end up with providers and patients ending up in this principal agent issue. Agent may not be functioning in the best interest, agent being the provider, functioning in the best interest of the principal, who is the patient. And you also end up with what the acronyms call SID, supplier induced demand. And what we're talking about is a SID, a supplier induced demand. Let's say it's a medical group and some, medical device salesman has come along and talked them into buying this new, let's say, X-ray machine. And so they're talking about, here's the X-ray machine, and you can do the X-rays in the office, and you're going to make you can be like printing money. And you can just imagine how these salesmen are pitching this. And so you have providers and patients come in and it's like, I've got this lower back pain, and what can you do for me? And the provider sitting there said, well, I don't know, that could be really serious. But you know what? I can get you an X-ray. We can walk down the hall. I've got a place we'll get you an X-ray. You don't have to worry about going anywhere else. Get the X-ray. I'll get it read for you. We'll take care of it. Getting money for the office visit, getting money for the X-ray. More than likely, you're going to get some money for reading the film. And that's what we talk about, SID, supplier induced demand. So now we've gone through 3: health plan, patients, providers. And we'll get into all 3 of these later in a little more detail. Then we've got government agencies, Health and Human Services. Everybody's heard of Health and Human Services. Probably the best known agency under Health and Human Services is Centers for Medicare and Medicaid, or CMS. And again, you've got these government agencies, and then I'm sure you've had classes before that go through this, is that the government agencies think they know more. They think they have a better understanding of what we need as individual consumers than we do. Government agencies work. Remember, we talked about in the last module about normative ethics and descriptive ethics. So normative ethics, how things should be, how we should act, and that's the government agencies. They base everything on this is how things should be, or this is how things ought to be. And so everything's driven by normative statements, normative ethics from the government agencies' perspective. In the state of New York, we had, state agencies, Department of Health, the Department of Financial Services, that were setting up there, monitoring all of these health plans, monitoring the way healthcare goods and services were provided. So Now you've got, and even though the government agencies may have social welfare or may have the best interest of social welfare, things go sideways on, especially if it's a grant. I mean, things go sideways, money changes hands, money doesn't end up uh, positively impacting, especially a needy population or disenfranchised population. Money doesn't actually flow to where it needs to go. Then you've got independent advocacy groups. They're focused on getting resources for this. They want the grant money to do this. Uh, they're more concerned with equity based, not so much health status based realigning of resources, realigning access to healthcare goods and services. And then lastly, when it comes to ethics, you've got HIPAA, and it's the Health Insurance Portability and Accountability Act of 1996. And it was put into play by Health and Human Services, again, which, CMS is an agency of Health and Human Services, and it was there to control the electronic exchange and the privacy and security of health information. Your information, my information, addresses, social security, diagnosis codes, sex, age, all of this is protected health information. And don't kid yourself. When it comes to ethics, there are constant individuals trying to breach these health, especially health plans and provider offices, trying to breach their systems to steal healthcare information. And this is what HIPAA is trying, and again, the acronym is HIPAA. And that's what HIPAA and that the 1996 Act is trying to mitigate or minimize, is the trying to protect the security of healthcare information for you, healthcare information for me, not only protected from hackers and people trying to steal it, but also protected from being utilized in the wrong way when it comes to provision of healthcare goods and services. And with that, I'm going to stop for a few minutes. And when we come back, we're going to talk about the advantages of ethical guidelines. Talk to everybody in a few minutes.